Now I would invite Dr. Jyoti Batra to tell us what to do on post-operative follow-up of therapeutic ulcers. This is extremely important in, like Dr. Vanati said, in fungal ulcers, when will you start your topical steroids? And what to do when you see a patient in your general OPD which has been referred to you, or you want to refer forwards after follow-up of therapeutic keratoplasty.
Reinfection or recurrence of the graft as well as the host edge. The secondary objectives are to promote epithelialization, to control the inflammation, and to closely monitor and manage the raised IOP. So if we talk about the clinical outcome in cases of therapeutic keratoplasty, what is more important is the anatomical success and the therapeutic success. The restoration of the tectonic integrity of the globe, and if we are able to completely eradicate the infection, our therapeutic keratoplasty is said to be has a successful outcome. Functional success as far as the visual outcome is concerned, it is desirable, but it is not the primary aim as far as the therapeutic keratoplasty is concerned. In the post-operative management, the continued use of the antimicrobial is the mainstay therapy for preventing the recurrence of infection. So if we talk about the topical as well as the systemic, both antimicrobials are important in the post-operative management. The corticosteroids, the use of corticosteroids, whether to use it in the early phase or not to use it, and what is the timing at which and what amount of dose and concentration is a very critical decision that has to be made. It depends on the various factors which we are dealing with when we've done a therapeutic keratoplasty. And equally important is the closer and regular follow-up of these patients. That can be a major determining factor for the success of the therapeutic keratoplasty. So if we talk about the topical antimicrobials, and if the surgery has been done for a bacterial keratitis, it is important to use the antibiotics with most sensitivity on a frequent basis till the epithelium heals. And if suppose the sensitivity is not known and the offending organism is not known, in those cases the combination therapy is given or a broad spectrum antibiotic is added. Till the further treatment is guided by the histopathology and the microbiology report of the excised cornea, which we've sent to the microbiologist. So as far as the topical antifungals are concerned, when we are dealing with the fungal keratitis and have done a keratoplasty in such cases, they also have to be used in frequently till not only till the epithelium heals, they have to be gradually tapered and sometimes have to be used over a period of 2 to 3 months. Similarly, when we are dealing with acanthamoeba keratitis, in those cases also the extended use of these topical amebicide drugs has to be used, which has to be continued even till a period of 6 to 12 months. And as far as the viral keratitis, if suppose we've done the surgery for the viral infections, in these cases it is desirable not to use topical antiviral agents in the immediate post-operative period because they are epitheliotoxic. So it's better to use systemic antiviral therapy, and these topical antiviral therapies do not add any additional advantage as far as the prevention of the recurrence is concerned. Now coming to the systemic antimicrobials have a definitive role as far as the management, the post-op therapeutic management is concerned, as compared to when we are dealing with corneal ulcers, where the topical drug therapy is the mainstay. When we've done a therapeutic keratoplasty, in these cases, systemic antimicrobial is to be continued, especially when we are dealing with bacterial, fungal or viral keratitis. process. So in bacterial keratitis, they have to be started before the surgery and to continue at least for a week post-surgery. And when suppose we've done the surgery for the fungal keratitis, in those cases it has to be continued for at least 2 weeks post-surgery, and the use of these the oral antifungals has to be extended for a period of 2 to 3 months also. If suppose at the time of the diagnosis the ulcer was perforated, there was a hypopyon or a lens involvement, or there is a limbal involvement. But what is important to remember when we are dealing with the fungal when we are giving oral antifungals to the patient, is to monitor their liver function test, and especially if we are using it for a prolonged duration. Similarly, when we've done surgery for viral keratitis, in those cases, oral acyclovir in the therapeutic dose has to be given for at least a week, and then the prophylactic dose of 400 milligram BD has to be given at least for a period of 6 months. It can be extended to 12 months if required. Oral valcyclovir is a good viable option, alternative to the acyclovir, because acyclovir is directly gastrotoxic. So it has the same efficacy with minus the side effects. So as far as the topical steroids, the use of topical steroids in the post-therapeutic keratoplasty is concerned, it's a very, very important decision which should be judiciously taken, because the main aim is to remove the infection. But yes, the inflammation equally is responsible for the failure of the graft. Topical steroids not only control the inflammation, they prevent the formation of the peripheral anterior synechiae in these cases, and also prevents the extensive corneal vascularization that can take place. So if the organism is known and the epithelium has healed post-surgery, the topical steroids can be given in the early phase. Similarly, in the viral keratitis, if the patient has been given systemic oral antivirals, in these cases, it has to be given from the start post-operatively. So in fungal keratitis, even if the epithelium heals and the epithelium heals and there are no sign of infection, it's better to withhold the use of topical steroids for at least 2 to 3 weeks after the surgery. Acanthamoeba also, you have to be very, very judicious whenever you're using the steroids. So systemic steroids have to be used only when there is intense inflammation and scleral involvement, in very, very select cases. Cycloplegics to prevent ciliary spasm. It's important to monitor the intraocular pressure on each visit post-operatively, and to add IOP lowering agents to take care of the glaucoma. To take care of the elevated IOP or glaucoma, because the persistent IOP rise post-surgery can damage the optic nerve permanently. So it's important that you add an anti-glaucoma drug whenever it is required, and it's important to consider to know that the prostaglandin analogs and pilocarpine has to be avoided as a first-line therapy in these cases, because they also increase the inflammation, and we've done the surgery in the setting of the inflammation. So artificial tears also, because there is associated epitheliopathy and they can be persistent defect in these cases. So artificial tears have to be added in such cases. Better to use non-preserved artificial tears. In the post-operative follow-up, it's the most important part is to closely monitor and see for any signs of infection, especially if you've done a lamellar therapeutic keratoplasty. The interface is one area where you should intently look for it. The graft-host junction, the host rim, and any in the area of a defect. These are the basic areas where the infection is more likely to be there. So you should closely monitor those areas. And apart from that, it's important to identify wound leak. Simple fluorescent test would identify that leak, and that the patient can be taken to a OR for the resuturing. The epithelialization is important, because a persistent epithelial defect can is a predisposing factor for as far as the infection. Can I take 2 minutes? So persistent epithelial defect is a ground for reinfection. So it has been shown that the fungal etiology, retroiris exudate, coexist in endophthalmitis, and larger grafts are susceptible to recurrence. So, and timely intervention can mitigate these factors. So, if we talk about the recurrence, so it's important, as Vanati ma'am was discussing the lamellar keratitis, therapeutic keratoplasty. So this, if suppose the interface has to be looked in intently on each visit, if we've done a therapeutic keratoplasty, here we can see a grayish white infiltration in the interface, which was treated with the penetrating keratoplasty. Similarly, the graft host junction, here you can see a gray white infiltration where the affected infected rim is excised, and then medical treatment is continued. In this case, you can see that there's a infection, the recurrence of the infection in the host rim, where it could not be managed topically with the topical antimicrobial therapy. Here, the patch PK has been done to contain the infection. So the epithelial integrity is also very important. So better to avoid epitheliotoxic drugs, and whenever in situation nothing works, the tarsorrhaphy comes in handy, and it helps in these situations. Punctal plugs and amniotic membrane transplant are also useful adjunct as far as the epithelial integrity is concerned. So to control inflammation, we've already discussed that corticosteroids can be more liberally given if we can be more sure of giving topical corticosteroids in patients where we've done the surgery for the bacterial keratitis, vis-a-vis when we've done the surgery for fungal or acanthamoeba infection. So secondary glaucoma is also one thing which we should definitely look in for. The inflammation, the hyphema, the pupillary block, and in the large grafts, compression of sutures, distorting the anterior chamber. These are the main reasons which can lead to IOP rise. And in the late post-operative period, the peripheral anterior synecdoche can also lead to a persistent rise of the treatment. Sometimes when, despite the maximum medical therapy, the IOP rise is not controlled. In those cases, secondary surgical intervention has to be taken, the TSAPC or trabeculectomy or a glaucoma implant after discussing with your glaucoma surgeon. So if suppose the patient has the graft size has been more than 10 mm, there are more chances of persistent epithelial defect, reinfection, and graft melt. So in the early post-operative period, it's important to look in for loose sutures, suture infiltrate if there is any. Just a minute. So suture infiltrate, then we have to remove the suture. If there is a suture infiltrate, it has to be removed and has to be plated on the bladder car. If there is a setting of a flat AC with flat or a shallow AC with the anterior chamber leak with the IOP low, that is a setting. Basically, it can be because of a wound. If there is a flat AC with a decreased IOP, that can be because of the anterior chamber leak, and it needs to be resutured. Persistent epithelial defect can be treated with the tarsorrhaphy or punctal plugs or amniotic membrane. In the late post-operative periods, what is important is to take care of the glaucoma part of it. Even if the graft fails, but if there is no extensive vascularization on the cornea, the anterior chamber architecture is maintained, and the IOP is under control, that is a good ground for future repeat keratoplasty or a DSEC or DMAC in the future for the final visual outcome for the patients. So as far as the final outcome is concerned, it is more encouraging as far as the bacterial keratitis as well as the viral keratitis. Now with the the timely management or timely intervention in fungal keratitis, it has been shown that the clarity as well as the cure rate in fungal outcome is also encouraging.